Hello, everybody. My name is Juan Luis Vásquez, and I'm a consultant urologist from Copenhagen, Denmark. And I'm very excited to start this webinar with you about improving bladder cancer care, advancements in pathways, technology, and techniques. And this is hosted by AIS, Advances in Surgery. With us today, we will have a very nice panel with Dr. Helena Burden from Bristol in the UK, Professor Bernard Malavaud, a dear friend, also known in the EU, from Toulouse, France, and myself, I'm an associate professor at the University of Copenhagen and working at Zealand University Hospital in Roskilde. So after a short introduction, I will start with novel strategies for outpatient care, then followed by Professor Malavaud on how advanced imaging is supporting treatment outcomes. Then we will continue with Dr. Helena Burden with optimizing bladder cancer treatment, and then we will have a panel discussion and we will finalize the webinar. So to set up the scene, I would like to show you, this is the bladder cancer treatment algorithm, including non-muscle invasive bladder cancer, muscle invasive bladder cancer, and metastatic disease. If we simplify it to the urological part, the surgical part, with non-muscle invasive and muscle invasive, that's how it looks like. So let's dig into the non-muscle invasive part. And here's where it becomes very interesting, because what we do for these patients is that we do the diagnostic to URBT, and here imaging is of extreme importance. We need to detect all lesions and remove them all in the primary surgery. So after that, we can stratify these patients into the different risk groups, low, intermediate, or high, and this will identify which adjuvant treatment these patients might receive. So you have, for low risk, you can do a single installation of chemotherapy. For intermediate risk, you can do adjuvant also chemotherapy with mitomycin C, or you can go for BCG, and for high risk, some patients will have a VTUR followed by BCG, and some patients will have a very bulky, large T1 tumor with carcinoma in situ covering the whole bladder, and they will go for cystectomy. And in some patients, if there's a recurrence or a progression, then the treatment will be a cystectomy. What you see here, if we focus on the left side, low, intermediate, or high risk, is that these patients will receive mitomycin C, adjuvant mitomycin C, and this is a lot of hospital visits. Mitomycin C is luckily very well tolerated. I mean, it's quite mild. I mean, there are not that many adverse events, but it is a lot of hospital visits. In our department, we give 18 installations. And then there is a follow-up. This is the Danish model. It's slightly different in what's stated in the European guidelines. We do 4, 8, 12, meaning that our first follow-up will be after 4 months, and then 8 months, and then 12 months. And then you have the high-risk tumors that will receive BCG. It's stated in the guidelines that it has to be given up to 3 years. In Denmark, we give it up to 1 year with the maintenance of 1 year. And this is also a lot of installations. This is 15 installations if you do 1 year, and there are a lot of side effects. So this is a huge burden for these patients. And then you have the patients that progress or recur, who might go for cystectomy. And this is also a challenge because it's a very big surgery. So we have already talked a little bit about the challenges, and we need to know that bladder cancer is a very common disease. It affects more than 500, almost 600,000 new cases per year worldwide, and these will increase by 81% by 2040. This is data from the Global Can 24. This is a lot of patients that we will be facing with. Then we have a lot of deaths also from this disease, and it's a highly prevalent disease because of the recurrences. And all of this, with including all the intensive treatment and follow-up, make bladder cancer the most expensive cancer disease of them all. So again, we have the challenges. We have a lot of recurrences. It makes it a high prevalent disease requiring multiple surgeries, adjuvant distillation treatments with multiple instrumentations and side effects, the close follow-up, and the huge cost. This is, of course, for the superficial tumors. And radical cystectomy, it's also a challenge for in terms of the invasive tumors, because it's major surgery, and not all patients are fit for this kind of surgery. And the other challenge that we have in bladder cancer is the patients. They are not always compliant. They are usually older and with lots of comorbidities. Usually, yeah. So they're often sick and have a bad performance status. So that makes it challenging to do the radical cystectomy. Therefore, it's of utmost importance that we find new alternatives to make the management of bladder cancer patient-friendly and cost-effective. And this is very important because we know there are new drugs coming. These drugs are costly. They might be super good. That's why we need to maybe save costs in other ways. So I'm very excited for what's coming next, and I will follow with novel strategies for the outpatient care. Thank you. Okay, so now we are going to talk about the strategies for outpatient care. This is a good way to move the patients from the OR to the outpatient clinic, saving costs. And we're going to talk a little bit also about imaging in a way to also to improving imaging in a way also to reduce some costs. These are my conflicts of interest, and those who might have relevance for this talk are highlighted. So this is what we did in my department. What we're trying to do is to reduce costs by and also and at the same time increasing the efficiency and quality. And that's something that we could do very easily by just implementing NBI. We had the equipment. We have this box in our department. We had it both in the outpatient clinic, and we had it already in the OR. Just by clicking one button, you could be able to just not use PDD.
And
this is how it works.
The white light around me hits the surface of the tomato juice. All colors except for red are absorbed. Only red is reflected, and that's how it reaches your eyes. So, how does NBI now work? Well, NBI uses not white light, but blue and green light. And when blue and green light hits the surface of the tissue, it is highly absorbed by little tiny blood vessels, but reflected by the surrounding tissue. And that's why NBI creates a high contrast between blood vessels and the surrounding tissue. Now, why is this so important? Well, small tumors are often surrounded by a larger number of blood vessels. And that's why NBI can help to detect and analyze these areas. So NBI supports early diagnosis.
So yeah, so what you can see is that it helps you detect the small blood vessels, right? And this is a good example because what we can see here on the left side is that is a normal urothelium. You don't see all these vessels, but what you see on the right side is an image of carcinoma in situ. And here you can actually see all these very small vessels that might be detected by MBI. And this is what gives us the image of frog egg configuration, which is what will maybe in a flat lesion will make a difference between a possible malignant lesion or a carcinoma in situ or edema. And that's what I was going to show you in this next video. You see, there might be a little bit area there that's a little bit thickened, but you are not totally sure about what it is, right? It might be normal. Maybe it's just some edema, or maybe it's nothing. But when you turn up MBI, you see all these dots, small dots that are these ending of the small blood vessels. And that's what makes you think that this might be carcinoma in situ. You see the other area also look thickened, but it's without the blood vessels. So that will help you also in terms of where you are going to take the biopsy from and do the right detection. So in terms of MBI, there are lots of studies comparing MBI to white light, and what they show is that it shows more carcinoma in situ and more papillary tumors. That's a good thing because that's what will reduce the risk of recurrences, and that's just fine. However, there are not many studies comparing NBI versus PDD. There is this very funny study, Japanese study, where what you can see is that they try to compare both PDD and NBI at the same time, but they are actually concluding that the use of both at the same time is beneficial. But the funny part of it is that they included only 10 patients, but you see that there are more authors in that paper than the amount of patients. And at the same time, I can tell you, I mean, it at this time that this study was performed, it was a logistical nightmare to do the direct comparison of MBI and PDD because you had to change the camera, you had to change the cable when you switch from MBI to PDD. This might be a different story now, where Olympus has brought their new camera that has both the possibility of MBI and PDD at the same time. And I know this because we did this in Denmark, where we compared directly MBI versus PDD. What we showed is that the sensitivity is very high, both for MBI and PDD is practically the same, and we did this directly. This study received a little bit of criticism because they said, well, the one modality helps the other. But what we were trying to show here is that MBI was not inferior to PDD, and actually all procedures were performed in a way that the first cystoscopy was done in white light, the second cystoscopy was done with MBI, and the last cystoscopy was done with PDD, meaning that if there was one modality that received an advantage, it was PDD because it was the last one, and PDD was at the time gold standard. Then we have the photo trial, a fantastic study published in New England Journal of Medicine. More than 500 patients, multi-center, randomized clinical trial, 22 centers in the UK with a huge follow-up, 44 months. And what they showed is that at 2 years, there weren't a difference in terms of recurrence. And the difference was that PDD was way more expensive, around £900 per patient. So it costs a lot of more money. So our experience in my department, I started leading the urothelial cancer team in 2019, and we had recurrence rates of around close to 60%. I introduced NBI in my department in 2020. And what I can tell you is that, well, I haven't looked at the exact I haven't looked at our recurrence rates directly, but we have the data, the Danish database that looks at this, and what we see is that our recurrence rates were reduced to now in 2024 to 13%, 1 year recurrence rate. So the introduction of NBI has not affected recurrence rates in a bad way. Actually, it was improved. And then again, we are saving in our department just by introducing NBI and skipping PDD. We're saving more than 200,000 euros per year. So that makes my boss super happy. And all of this just by pushing one button. So this is Arne. This is, of course, not a real patient, but a photo I got from the internet. But that's a typical bladder cancer patient, an older man in the 70s, heavy smoker, not very compliant, maybe with lots of comorbidities. And these patients are not so easy to treat. Therefore, we need to try to find alternatives that are more less invasive and less harmful for them. We know that from Danish studies that 62% of patients had unscheduled contact with the healthcare system after hospital discharge. This wasn't a study. This was not TRBT. It was a TRP. But this is transurethral surgery. And on the other hand, we know that a substantial amount of patients had voiding problems after a mean of 12 days after a hospital discharge. So these cost money and does affect quality of life. We also know from this Danish study that mortality can be increased by the increased amount of TURBTs being performed under general anesthesia. And this is a very interesting study because we looked at 11,000 patients, and something that was found is that around 53% of these patients actually didn't have a real recurrence or a real pathology when the biopsies were taken, meaning that patients were put on the general anesthesia and got a procedure for nothing, which is something that you might have to take in consideration because our bladder cancer patients are quite frail and we need to be very careful with them. So something we have done to tackle this issue is that we have introduced laser ablation as an outpatient treatment. These actually made it to the EU guidelines, which is quite good. The data is not fantastic. This is one of a systematic review published in the European Urology Focus with 17 studies. 9 studies were using laser, 6 studies used the Holmium laser, but none of them used the thulium fiber laser, which is what I use in my department. None of them were randomized clinical trials. Most of them were prospective cohort studies, and the oldest is from 1981, and the latest is from 2019. So the level of evidence here is quite low. The vast majority of the tumors were intermediate risk, non-muscle invasive bladder tumors. As you can see, 86% are TA, 80% are low grade. The mean number of tumors is 4 with up to 30, and the mean tumor size was 6 millimeters, being the largest 3 centimeters. Overall, the recurrence rate was 47% and an average follow-up of 22 months. But in any case, it is very difficult to conclude anything from this because all these studies there is a high heterogeneity in these studies. However, it seems like regardless of the type of laser that was used, the procedure was very well tolerated with no major complications, and the mean VAS score, pain score was 1. Particularly from the study of Gomez, the holmium where he used the holmium laser, 100% of patients reported that they prefer laser over the TURBT. Here we have to take to have in mind that only 72% answered the questionnaire, but yeah, there was a high preference for over the laser ablation. Then this Danish study is the best data that's found on outpatient laser ablation. This is a randomized clinical trial including 206 patients, all of them intermediate risk, low-grade tumors. Here they used a diode laser, and what they show is that in terms of recurrence, the laser ablation was not inferior to TURBT. And here you can see that they had definitely less voiding symptoms and better quality of life. And 98% of these patients preferred laser over TURBT. This is our own data, what we have collected so far. This is unpublished. The publication is coming very soon. And we did a single-arm prospective cohort study. 57% of the patients were intermediate risk patients, meaning that we also had high-risk patients in this cohort. It was very well tolerated with a VAS score of 2. And what you see is that the recurrence rates at 4 months and 12 months are quite low. And here is where it becomes quite interesting. This is the amount of people being used at the OR just to get a patient ready for the procedure. And I apologize, this slide is in Danish, but this is an image that we did to convince the management of the hospital to let us buy an extra laser for the outpatient clinic, because here was where you can see how you can optimize the use of your resources, because you can see clearly that the amount of people involved or staff involved in an TURBT under general anesthesia, and when the difference is when you do it in the outpatient clinic, a lot less staff is being used. And this is a picture of the team doing laser ablations. The guy in the middle is that he's not doing laser ablations. He's my boss. He's there just for the photo opportunity. But what I'm trying to show here is that it's either one doctor and a nurse assisting, and that's it. No more. It's only 2 people in here, and the amount of time being used, it's 2 hours, because the patient gets into the outpatient clinic, gets the local anesthesia instilled by the nurse in the bladder, stays in the outpatient clinic walking around for 1 hour, and then the procedure is done. And it takes, let's say, 15 minutes. So it's no more than 2 hours in total. So remember, Arne, he needs a very much, he is not the patient that's most fit for repetitive general anesthesia procedures. So therefore, we usually recommend them to get the laser ablation done. And the thing is that this is something that I have experienced very much when we are seeing these patients with recurrences, and we ask them, okay, what would you prefer? Would you prefer the TURBT or the laser? And once they've tried the laser, they tell me they would never go back to the TURBT. So please think that it is very important to make the management of bladder cancer patient-friendly and cost-effective. Thank you very much. This is my team. I would like to introduce Rose, Amy, and Peter, and Vibeke and Stine, who are working very hardly to get all these recurrence rates and progression rates as low as possible in my department. Thank you very much.
So good morning, everybody. I was required to give a talk about advanced imaging and bladder cancer, and let's go. The story started over 20 years ago when we acknowledged in a EORTC study that actually the results of our treatments, endoscopic treatments, were highly dependent not only on the tumor, but also on the surgeon. And therefore, this alluded to some very strong and very important technical points in the treatment of non-muscle invasive bladder cancer. Now we have to review very rapidly the reasons why those technical points are of high significance in the treatment itself. First, the target, the tumor, may not be accessible. Second, it may not be seen. It may not be recognized. And last but not least, but that won't be covered today, the target might not be resected properly. That would be a separate issue. Well, the first issue is accessibility of the tumor. And we know that when we're using a rigid telescope, this rigid telescope is actually limited by the lens that we're using. With a 12-degree lens, it's very hard to see the regions which are close to the bladder neck. And unfortunately, this is a very significant situation in the bladder. And it is also the lens that is usually used by the surgeons. It would be better to use a 30-degree lens to acknowledge this part of the bladder, or even a 70-degree lens. But this 70-degree lens wouldn't allow us to do the resection. So it's we have to balance the benefit of vision and the benefit of quality of resection. And 12-degree is not too bad, but we still have to keep in mind the limitations of this lens. We can also use fiberscope, video fiberscopes. And those, as you can see there, give you an excellent access to the entirety of the bladder, give you a very good knowledge. And therefore, you can translate this knowledge into strategy to perform the resection. Therefore, any information that has been gained during the preoperative videoscopy has to be recorded, either on a sheet, on a paper, or even can be done immediately before the surgery so that you can actually personalize your surgical treatment. And this is clearly acknowledged in the EU guidelines, which clearly state that the endoscopy is a very important strategic point in the management of the bladder cancer. But we also have to understand the target itself. What is a target and how do we acknowledge this target? Therefore, a few words on our vision, because this is based on our visual evaluation and understanding of the tumor. The receptor, the ultimate receptor, is the eye, and the eye is perfect. It gives a very pinpoint accuracy and also a 3D vision. So there's nothing better than the eye. But unfortunately, between the eye and the target, there are many physical and non-physical elements that play a role. We have to just spend a few seconds on what do we do. When we do white illumination, we have a selective absorption of certain wavelength by the mucosa and the submucosa. Those wavelengths being absorbed disappear. Therefore, whenever they've been absorbed, it's black. Or we have a reflection of those wavelengths, of other wavelengths, and then they give some color. And this is the combination of absorption and reflection that actually gives a complex vision that we have when we do an endoscopy. And there you can see a ureteral orifice. This information has to be captured by the system that we use, a telescope usually, and transmitted to what? Transmitted to the eye through cables and through a monitor. And the eye itself has to inform the brain. Therefore, we have to acknowledge that capture and transmission through a telescope, captured by the human retina, brain processing and conclusions are not trivial matters. And they are not trivial matters because they actually are impacted by the quality of the equipment we're using. Capture can be used with a lens, like with a rigid telescope, or chip on tip, like a videoscope. The transmission can be digital, can be fiber-based, can be done through lenses. The monitor, there are very different qualities of monitors on the market. The human retina understands better things that are contrasted. And by the way, the sun is actually troubling me a bit. And then the brain understanding. You have to understand. And to brain processing, it's understanding. And understanding is training. So if all in a few seconds, we can summarize that by saying that what we have at hand now to understand the bladder and actually to train our brain is molecular imaging, white light imaging, neural imaging, and augmented reality imaging. Let's start with a very simple question. What are the hallmarks of cancer? The first and foremost is that the growth is uncontrolled, leaving room for exophytic lesions. And those exophytic lesions are important because we can analyze them in size, in location, even in their aspect and the number. And this is what is at the foundations of the OITC risk tables that we all use. Even we can go a bit further than that because the aspect, the general outline of the tumor is also very informative. We very well know that something that is highly papillary is usually low grade, while something that is stiff and sessile is usually high grade and possibly T1 lesion. We can also visually identify some slight irregularities on the bladder wall. And those flat irregularities can allude and can lead to the diagnosis of carcinoma in situ, which is characterized by a thickening of the mucosa and very highly dense submucosa, vascular submucosa. So, in one word, when we get to white light imaging, we have a rationale, that is, we look for the vascular fronts of the exophytic lesions, the exophytic aspect of it. The physics is reflection and absorption, and the characteristics can lead to the detection of 3D or flat lesions. Let's go to molecular imaging. Molecular imaging is based on a second hallmark of cancer, that is, it is highly dependent on glucoses, glycolysis on its survival, actually, life and survival. And this is called the Warburg effect. And this Warburg effect put at the center of this cycle that you just saw one very important molecule, that is the M. And this M has to be completely processed, has to incorporate in itself some iron ion. And it cannot do that. Cancer cells can't do that. And because they can't do that, we can take advantage of it by inserting in the bladder a precursor of the AIM that is accumulated in cancer cells, but blocked at the final stage of the production of AIM, that is protoporphyrin 9. And this protoporphyrin 9, as you can see on the screen, is actually pink when you eliminate it in blue. Therefore, give us a direct information about the molecular imaging of this specific area of the mucosa. Unfortunately, you find some protoporphyrin 9 in all cells, normal and cancer. The difference is just that we have much more many more molecules in cancer cells than in normal cells. So if you take a tangential vision of a normal mucosa, it will be slightly pink. If you have an inflammatory lesion, it will also be slightly pink. So you, again, have to train yourself before you can get visions like that, where the carcinoma in situ is clear-cut and very easy to detect and to outline. So defective metabolism is also a nice way to identify cancer. The third hallmark is angiogenesis, and this is well known since Judah Folkman papers in 1971. There is no growth of a solid tumor without angiogenesis, and this angiogenesis can be actually leveraged to identify cancer by highlighting the vessels. And to highlight the vessels, we select the wavelength that are absorbed by the vessels, 450 nanometers and 5 140 nanometers, and we process them somewhere so that we can get information. Information not only about the vessels, but also about the scattering of the light by the size, the bigger size of cancer cells. Cancer cells have large nuclei. They scatter the light. This information can be actually transcoded in information. And this is the kind of information that you get. You get the vessel vascularity, the vessel density, but also information about the mucosa. And it's super important to acknowledge that in a normal bladder, the mucosa is so thin that it cannot be seen. Therefore, if you see a high microvascular density and mucosa that has been raised enough to be detectable, this is a suspicious area. And here you have now a vision of a lesion that has cited PTA and carcinoma in situ. So, and you see clearly there that you see better the vascular fronts, and you also see that the mucosa is visible. Normal mucosa is not visible. So this is highly suspicious, not suspicious, not only suspicious, but distinctive. Here we have another lesion. Surprise. It is slightly exophytic, it is slightly vascularized, and we also see the mucosa, but it's not cancer. It's nephrogenic hyperplasia. So again, we have to train and we have to understand and we have to develop our skills in understanding the structure and the structure of the normal and abnormal mucosa. So if we look at narrowband imaging, we can have information about submucosal vessels and about the mucosa. That's not the end. The end, because we know that the human eye is very sensitive to contrasts and to the balance of colors. So when we get a native image, we can also play on the balance of colors and on the contrast. And this could be called artificial imaging, but why not? Or image manipulation. Nevertheless, it is based on the ability of the brain through the eye to understand better things that are clearly outlined. And there we have different systems from different companies that plays this role and that play this well. Okay. And of course, in the near future, possibly we might get something based on artificial intelligence. So in a few words, this is where we are. We can look at it under white light, molecular imaging, narrowband imaging, image manipulation, possibly someday artificial intelligence. So we have information. We have information. But then this information has to be processed by the brain. And the question is, does it play a role in the outcome of the management? Brain is important. Look at this one. We all see a lady there. But how old is she? Some people we see a 20-year-old lady, and some others a very old 80-year-old lady. Brain plays many tricks. And ultimately, we have to master our brain, therefore our training, our understanding to improve the treatment. So white light plus PDD, molecular imaging, plus NBIs, plus SPIs. Well, at the end, what should we do? Well, the fact is that there's only one thing we are certain of, is that white light imaging is not enough. It has to be complemented by something else, whatever, PDD, NBI, SPIs, whatever system, because white light imaging is prone to limitations. And this was largely demonstrated in the literature. In terms of detection of the lesion, in terms of quality of resection, but the literature is not too strong about the impact, the ultimate impact on disease-free survival and, of course, progression-free survival. So we have different literatures, large Cochrane database reviews that all say that they have a low certainty evidence that it may reduce the risk of disease recurrence, but it's a low certainty evidence, not very high, a very strong recommendation. Even though we are certain, and we published, that the fact that you use narrowband imaging at the time of surgery actually increases the odds of detecting more lesions. Not only the target lesion that might be 1.5 centimeter wide, therefore quite easily seen, but also satellite 1, 2, 3, 4 millimeter wide lesions that are clearly very often overlooked during the resection. The literature, therefore, is not too definitive on that point, but I do insist white light imaging is not enough. So to conclude, we have strong recommendation with PDD in the detection of flat lesions like carcinoma in situ. Therefore, any lesion that is suspected of being high grade based on the preoperative cytology or the perioperative outline would definitely benefit from PDD. The use of narrowband imaging is shown to improve the detections of small satellite lesions and suggested to improve the disease-free survival, but not the progression-free survival. And all the other systems based on image manipulations actually have, roughly speaking, the same results. And this is clearly what is emphasized and by the NICE UK recommendation, saying never do a resection without something else than white light imaging. And now I have to thank you for your attention. Thank you.
Thank you for asking me to talk today. My name is Helena Burden. I work as a consultant urological surgeon specialising in non-muscle invasive bladder cancer in Bristol in the UK. My colleagues have already talked to you about technological advantages to bladder cancer, and I'd like to talk to you more about the operational side of bladder cancer pathways. So my experience is based within the National Health Service within the UK, and all health systems worldwide do operate differently, but there are many common challenges, and the biology of bladder cancer remains similar worldwide, so the principles remain the same. These are my disclosures. So I'm going to start by talking to you a little bit about my background involvement with bladder cancer pathways for patients and why I believe it's so crucial in their management. I then want to highlight a few areas within our current pathway that I believe are beneficial for our patients in offering them personalised care and that might be helpful to other clinicians involved in bladder cancer. So I'd like to start by explaining how I became a non-muscle invasive bladder cancer subspecialist and the reasons behind my interest in bladder cancer pathways. I was appointed as a consultant in non-muscle invasive bladder cancer with my colleague called Kate Warren in 2016 because our department had a problem with a high number of complaints, patients who'd unfortunately been lost to follow-up and presented with significant disease progression. And this was namely within the non-muscle invasive bladder cancer population. We have a highly renowned robotic pelvic team leading the cystectomy pathways, but at the time, no one was specifically concentrating on the high number of non-muscle invasive bladder cancer pathways patients. And I think this is the same in quite a number of units. But we know that 80% of all bladder cancer is non-muscle invasive bladder cancer. And muscle invasive bladder cancer receives a lot of the focus, and quite rightly, it's a life-changing disease. However, the vast majority of our patients with bladder cancer do have non-muscle invasive disease, and many of these patients will be with us for life, with a high risk of recurrence and progression of their disease. And in many units, certainly in the UK, these patients don't have a dedicated consultant and don't always receive the consistency of attention that they and their disease characteristics deserve. In England alone, we perform upwards of 32,000 TRBTs per year, and it's one of the highest volume operations in urology. We know the disease biology significantly affects these patients in terms of recurrent hospital visits, procedures, and anxiety regarding these disease outcomes. So when we started as consultants, we performed a high-level process mapping exercise to look at our current pathways and compared what we currently had in place to what we would want an ideal pathway to look like. This was really our starting point in 2016. This is an example of a low-level pathway map purely for a TURBT, which we looked at. However, you need to be able to map all these areas in a patient's journey to quite a high level. And if you want to improve your bladder cancer pathways, you need to know your starting position and then work through the fine detail of each individual element. You also need to know what your vision would be like for the ideal or future pathway, and then utilise the principles of change management to achieve this. Over the last 8 years, we've worked in stages on our bladder cancer patient pathways, initially by process mapping and closing all the safety loopholes where we could lose patients in our systems, and then developing a team, organising up-to-date kit and following evidence-based medicine to develop expert guidance and surveillance strategies. And where we are now is in our cutting edge phase, where we aim to be leading the way in bladder cancer pathways with technology, including involvement in research. So our current pathway now has all these elements in place that we were missing before. It's safe, it's evidence-based, and hopefully reaching the cutting edge stage. So I want to concentrate on 3 areas today which are crucial to our pathway to provide excellent patient care. The first is the development of non-muscle invasive bladder cancer specialists. We're a large tertiary hospital with 28 consultant colleagues. 3 of us are currently undertaking non-muscle invasive bladder cancer. However, there are many of our colleagues and resident doctors who refer into our team, provide flexible cystoscopies for our patients and perform some of the core operating, which is why it can be tricky for our non-muscle invasive bladder cancer patients to receive consistent care. Our model is of leadership by the non-muscle invasive bladder cancer team, who provide a lot, but not absolutely all, of the care for our patients. However, we have full oversight of our patients as soon as they enter our system. And this is what our non-muscle invasive bladder cancer team currently looks like. And why do I feel this model works? Well, in our hospital, we no longer have any patients lost to follow-up presenting with advanced disease. We have a very safe pathway. But more than that, there's significant evidence showing that less experienced operators have worse outcomes. And this makes sense when other centres have proven that high-volume centres get better results for other disease processes. And the same is true of bladder cancer and TURBTs. This paper looked at TURBTs with more and less experienced operators, and they found that the more experienced operators get a higher detrusor muscle in the specimen and lower residual tumour than less experienced colleagues. And we know that detrusor muscle in a TURBT specimen is amongst one of the quality indicators of a good TURBT. We know this from the work of my colleague, Professor Mariapam in Scotland, that the achievement of good quality indicators for bladder cancer leads to better bladder cancer outcomes. And he's evidenced this within the Scottish QPI programme. In Bristol, our figures match this programme with our model of non-muscle invasive bladder cancer leadership. So the second pathway area I'd like to highlight in the pathway is that of risk stratification. We all know that not all bladder cancer is the same. There's a wide disease spectrum within the title of non-muscle invasive bladder cancer, and bladder cancer can range from little threat to potentially fatal disease. Despite this, patients often remain on a common pathway. Therefore, there's huge importance in accurate assessment and diagnosis, risk stratification, and offering appropriate treatment options as a result of this and using our workforce efficiently. This needs a whole team approach with a process in place for risk stratification, and we need to be able to identify complex and high-risk bladder cancer patients at the outset. Can we, as urologists, do this? Well, actually, the evidence is there to show that urologists are pretty accurate at identifying high-risk disease at first flexible cystoscopy. So then we need a process in place as part of our pathway to risk stratify these patients. And one crucial checkpoint for us to risk stratification and management of our resources is our weekly bladder scheduling meeting, where we review all cases that have been listed in the department. We have a non-muscle invasive bladder cancer present, a bladder cancer nurse specialist, a member of our admin booking team, and one of our research nurses. We review all the weekly listings and then check this is appropriate by looking at the frailty status of the patient and their comorbidities, looking at their bladder cancer current characteristics with the mapping that's been provided, and then looking at their bladder cancer background and decide whether they're listed for the most appropriate operation. If not, we may change that, and we may offer them adjuncts that we think are appropriate for that particular procedure. We also consider the timescale. Is this a very urgent one or a lower risk case? And in the high risk cases, we identify them for a specialist non-muscle invasive bladder cancer TURBT list. And this is what that specialist list looks like in our hospital, where we perform day case TURBT and surgery for the majority of our patients in a team approach with all of these elements in place. The third point I'd like to highlight in the pathway is having appropriate technology in place to provide day case TURBT. So our criteria for day case TURBT is essentially day case by default. There are a couple of exclusion criteria, but they're not huge. So we certainly wouldn't consider large tumours, anticoagulation, or particular age or ASA to be contraindications. But we would consider a contraindication if there was no competent adult to stay with the patient overnight, or they were unable, or someone was unable to manage a catheter at home for them. So most of our patients are day case. We have a number of key technologies in place to provide day case and other surgery for bladder cancer, some of which have already been highlighted by my colleagues. And these are the technologies we have in place in our hospital. A key to managing day case TURBTs is appropriate hemostasis, which the bipolar plasma Olympus system helps us achieve. And studies have indicated that bipolar resection of bladder tumours has a lower incidence of complications, particularly importantly bleeding, but also TUR syndrome, obturator jerks and bladder perforation potentially. So bipolar TURBT is safe and efficacious. There are other enablers to day case TURBT. It's not just about the technology, you have to have an appropriate pathway in place. And some of the key areas of our pathway involve single installation mitomycin in theatre, no routine post-operative irrigation, having the ability to have an outpatient trial without catheter if the patient needs to go home with a catheter. And then important is managing patient and staff expectations, which we do via teaching for patients and staff and patient information leaflets. So looking at some of our results, in this study we looked at 100 of our patients, and we found that 73% of them had day case surgery as planned. 7.5% of them ended up having unplanned overnight stays. And we don't find that having day case TURBT compromises any of our results. Certainly the rate of readmission is low. The overall readmission is 9% within 30 days, but actually only 66% of this was due to urological issues. So a day case TURBT is safe. So in conclusion, I think it's important to develop safe, evidence-based and cutting-edge pathways for bladder cancer. It's important to have leadership and ownership of the non-muscle invasive bladder cancer patients. We must risk stratify within the pathway to give our patients the best outcomes and use our resources appropriately. And day case TURBT is achievable with appropriate pathways and technology in place. Thank you.
Okay, well, thank you very much, Professor Malavaud and Dr. Burden, with these very nice lectures on strategy, pathways, and how we can make non-muscle invasive bladder cancer care more patient-friendly and cost-effective, and never forgetting the quality. So I was very inspired by your presentation, Helena, I was thinking about in terms of redesigning your pathways, which was quite fantastic. What was the biggest cultural institutional barrier that you had to overcome in order to achieve this?
Oh, you start
Um,
on very high ground, I understand. So, well, actually, the main hurdle to improve the care in non-muscle invasive bladder cancer is actually to change the vision of the institution. On this disease is not a menial disease. It's not a small tumor that has to be taken out in a few minutes. It's a complex one. It's a costly one, and in some cases, the surgery requires a lot of experience to remain safe and effective at the same time. It's not too difficult to be safe when you do a shitty job. It's sometimes a bit challenging to be effective, to remove all the tumor, visible tumor. And we may discuss the different means of identifying something that is suspicious, white light, normal imaging, image manipulation, and possibly artificial intelligence one day. And also taking out all the tumor, including some difficult areas to reach. I mean, the dome of the bladder, the anterior part of the bladder, the vertical line, which may be good indications of aggressive endoscopic surgery. So, honestly, main limitation, the vision that we all have on this disease that is not a simple one.
Thank you. But well, what about you, Helena? You did some great changes in your department regarding the pathways. Did you face any cultural or institutional barriers to implement that?
I think I mean I agree with Professor Malavaud. It is getting the vision. So we're all trained in the UK to have TURBT as one of our sort of core procedures, I suppose, when we become consultants. So it's considered to be a very core procedure that everyone can do. And I think it was really changing the mindset to it being not one that can be a TURBT to be slotted on the end of a list after several other things being done by anyone in the department, but for it to be certainly complex TURBTs to be done by very specific people, doing high volume and managing those patients safely with personalized patient pathways. So I think that was probably the sort of the mindset change that has evolved over the last sort of 8 to 9 years while I've been a consultant there.
Yeah, there's certainly, I believe that that the TURBT is an easy procedure, and it's definitely not, and that we are having the most unexperienced people doing these procedures, and that reflects in our recurrence rates and our progression rates, and that's why we're here now discussing this, right? So I was also a little bit interested in Helena, in your weekly bladder scheduling meetings. How does it work? Who leads those meetings, and how what do you do to make them efficient?
So they're led by, so in our institution we have 3 consultants who are focusing particularly on non-muscle invasive bladder cancer, and we don't do absolutely all of the TURBTs in the centre, but we certainly lead the service and do all the complex ones and the ones that need particular care and attention. So it's led by one of our non-muscle invasive bladder cancer consultants. We've got admin support from the booking team, or whatever they might be called in other people's institutions, but the booking team. We also have the research team there as well, so that we can identify patients for trials. So we're running one of the Moonrise trials at the moment, so trying to identify patients at that point for trials. And then we have our cancer nurse specialists and our resident doctors there as well, so that they can sort of learn what we do. And it tends to take the format of about an hour's meeting on a weekly basis, where we look at all of the cases that have been booked the previous week for bladder cancer. So any of the TURBTs, any of the rigidum biopsies, any of the transurethral laser ablations. And we go through all of those bookings and just check whether we felt that it was an appropriate listing. Did they need any adjuncts? So are we looking at needing narrowband imaging? Are we looking at needing blue light cystoscopy for this patient? Would they actually be better off if they're very frail? Would they be better off with a Tula rather than being booked for a general anaesthetic TURBT? Do they need mitomycin? All those sorts of adjuncts that actually, if you don't plan it at that stage, are sometimes quite difficult to arrange on the day, and maybe are not in people's mindsets on the day if it hasn't been thought about beforehand. So that's what we do with that meeting. Yeah.
Great. We have something, but is this separate from the MDT, or do you do it together? It's separate.
Yeah, no, it's separate from MDT. So we have a pelvic oncology MDT. So the non-muscle invasive bladder cancer specialists will be there along with our cystectomy team and the other members of the MDT. So no, we tend to keep those separate. So it tends to be the non-muscle invasive bladder cancer team that are looking at that bladder scheduling meeting. It's interesting to hear you. So you do it within your main MDT, do you?
No. Well, we don't do the booking meeting because we have a very highly very good secretaries that know which patients go which way, depending on what we book and how to do it. And in our department, that's something that I did a similar thing as you did, changing the mindset of TURBTs are for everyone. And they're still for all residents, but instead of just being done by the residents without supervision, it's with qualified supervision. So the TURBTs in my department are done by the bladder team or by a resident under the supervision of one of the team members in the bladder team. So it's either by qualified people or under supervision of qualified doctors. And again, it took some time to make other consultants understand that what they were doing was not good enough. We had recurrence rates. When I started as a consultant in 2019, we had recurrence rates close to 60%. And of course, I made some changes. But the most important change, in my opinion, from what I did, it's not very much about intravesical treatments or other stuff, but it's about the TURBTs changing. And now we have in 2024, we had a 1-year recurrence rate close to 13%. So the reductions has been brutal because of focusing on the quality of the TURBT. So yeah, but the booking of the TURBTs is by the secretaries that know how to book them in that direction, and then we have those separate MDT.
If I may, I have a few comments on those two interventions. The first one is that I think the key word is complexity. And you say qualified people. We may be qualified for something simple and not qualified for something more complex. So the crux of the matter is actually to define complexity. And for that, it is mainly based on experience. And we published some time ago grading of complexity in TURBT. And it's amazing the number of factors that experts consider to be impacting the degree of complexity. Complexity being assessed in terms of length of surgery and also in terms of morbidities induced by the surgery. Meaning that it does relate to the patient, it does relate to the tumor, it does relate to, and the patient, for instance, age and female sex. We know that it's always a bit more tricky to do something in an old lady than in a young male, irrespective of stage and the grade. Patients, the tumor characteristics, and also the equipment. I do believe that the technical surroundings of the surgery do impact on the outcome of the surgery. Not only the quality of the surgery, the surgeons, the patient's volume, but also the kind of equipment that we have. And in that matter, Helena just alluded to new systems of vision, NBI, white light imaging being complemented by NBI or blue light or something else. I'm also keen and actually very partial to having an expert review of the entire bladder lining before engaging in the TURBT. And to my mind, the only way to do that is to use flexible cystoscope. And I'm very, very partial on that because that's the best way to have a thorough vision of the bladder lining all across the bladder, even in very large bladders. And also to have, by retroversion and retrovision, some understanding of the trigon, the bladder neck, the interior part, and so forth. And of course, whenever we have a diverticulum or diverticuli, the best way to evaluate each of those is actually to do it with a flexible cystoscope. We can't do that with a rigid telescope, even if we switch from 12-degree lens to 30-degree or even 70-degree lens, which we never do actually. So complexity would be the first step. Changing the vision of the staff is the first one in the organization of the program, a surgical list. Second is acknowledging that it may be complex, and therefore qualification, being a qualified personnel, does change according to the complexity of the case. And third, the best way to assess the complexity of the tumor characteristics is definitely, in my mind, but I'd like to have your opinion, Helena, on that, is to do a video flexi before engaging in the surgery. Well,
Bernard,
points.
I know you advocate for the use of flexible cystoscopy, and you do it actually before, like during the TURBT. So right before you do the TURBT, you do the flexible, and then you continue with the surgery. But what's your thought about because I'm just thinking about comparing it to our setup in my department. What we do is that all patients undergoing TURBT, they have, of course, have undergone at a flexible cystoscopy. Do you think is that enough, or would you still advocate for a flexible cystoscopy during the TURBT?
Good point. Let me put my EAU hat. EAU says that we should document all cystoscopy by EORTC or EAU bladder diagram. So this is by the book. But please keep in mind that the one who will be doing the cystoscopy is not necessarily the most qualified people in your team. And hopefully that you are better qualified than him or her when you are doing a surgery. So yes, I do abide by the rule that any diagnostic cystoscopy should be documented, no doubt. That this document is essential, and we have diverse forms of checklist prior to the surgery, including in the EAU guidelines, where you have pre-operative checklist to follow, and using the checklist does improve the quality of the recurrence-free survival and not progression-free survival documented. But I do believe, and I'm very partial about that when the surgeon is actually taking 5 minutes before engaging the TURBT to review the entirety of the bladder using the best system available at the time, which is video, flexi video, it's always beneficial. If not, to tell the anesthesiologist, it might be slightly longer than you expected.
All right, now sorry, no, I just wanted to continue the discussion on because we have been talking about inexperienced and experienced, and Bernard, in your talk, you actually highlight that what the eye can see, the surgeon can treat, right? And so what do you also, for you, Helena, how do you think would be the best way to train our residents to train their eyes and brains and make them better detectors, or should we rely on AI for that?
That's a difficult one, isn't it? They've certainly started using it in our. I know our GI surgeons use it in colonoscopies now, and they have little like red boxes that come up saying this is a polyp, this is a polyp, and I haven't seen it used in cystoscopy yet personally, but I'm sure it's around somewhere. I mean, we yeah, exactly as Professor Malavaud says, we use bladder mapping. We take videos, we take pictures, so we have training. So when we do our bladder scheduling meeting, we have access to those pictures and the videos, the bladder map, so that we can plan. So I have to say I don't routinely do a flexible cystoscopy, but it does depend how long it's been since the patient was listed and who listed them as well, slightly to some extent, and then what the vision's like of the bladder. I mean, I think we've certainly found the PDD has been really, really, really good for training trainees, because it does make it much more obvious where the tumour is. There are other adjuncts as well, like MVI, that can be helpful as well. And I think some of those adjuncts can be incredibly helpful when you're training the residents, just to get that eye around. And obviously you spot things that you wouldn't have seen with the white light as well, obviously, which is why you're using them. But I think certainly some of the adjuncts can be incredibly helpful with training.
May I? I think training is understanding. So the very first step for the surgeon, the young surgeon or the surgeon to be, urologist to be, is to understand the structure of the bladder. Because we are dealing with a disease that involves only a urothelium, a mucosa that is 30 to 60 micrometers thick. So it's extremely thin. We have to understand that the structure of the bladder is different from the base of the bladder, the trigone, and the dome. We have to understand that the disease itself has different patterns of progression. So understanding the disease before engaging into TURBT. At the moment, we do exactly the reverse. We ask a young surgeon, take it out, and then you'll understand. No, that's not the way. The way is to start to understand the anatomy of the bladder, not only the inner lining of the bladder, but also the structure, the multi-layered structure of the bladder, and also the organs at risk which are around. And then, based on that, and understanding the different sources of energy, monopolar, bipolar, laser, and so on, then you can safely apply them to an organ which is actually quite complex. I remember that when young residents started their surgery, they were dreaming of doing a nephrectomy, a total nephrectomy. But in terms of viability of cases, a total nephrectomy, radical nephrectomy, is much simpler than the complex TURBT. So understanding is important, understanding the anatomy, understanding the histology, and understanding the energy that you'll be using. And based on those three understandings, when they're joined, then you can start doing your surgery. And the surgery is always simple and very effective in some specific locations. I always say that when you want to try a new surgery, just take a 1 centimeter wide lesion of the trigone. It's a piece of cake. And this will be a fantastic initiation to overcome the worries of actually cutting an endoscopy when you have only one instrument. We are all used to having forceps and scissors, and then we have to make use of one single instrument, both as a forceps and as a scissor, to distract and to cut. So we have to overcome many limitations, and it might have been more difficult for my generation, where we used to be trained just to scoop out the tumor, actually. And now we want to dissect it. And dissection refers back to the anatomy of the bladder and also to the histology of the disease. Understanding. Training equals understanding. And training also equals a benevolent attitude for the seniors, which we will accept to spend more time looking at some clumsy moves in order to have the younger ones more proficient in their surgery.
Thank you. Now, if we move on into the image enhancing ways. Bernard, you advocate for combining white light with NBI and PDD, and even you mentioned molecular imaging. Do you is there where did you draw the line between enough and too much?
Okay. Enough is when you have done a good job. So let's go back to white light. And we know that doing just white light is not good enough. Just have to refer to the nice recommendations in the UK, which are quite clear, saying white light imaging by itself alone might overlook some lesions that would have been detected by using different systems. Those different systems are many. There's NBI, which images the vessels and the thickness of the mucosa. There is PDD, which actually is equals molecular imaging, because what you're looking at, it's a molecular abnormality. And there are also some other systems of image manipulation, which actually are not exactly based on a physiopathological concept, but works as well. I'm thinking of the source system, for instance, which is just I manipulate the image and increase the contrast, and I see better. And if I see better, I understand better. If I understand better, I treat better. Those are the three directions. At the moment, as Helena said, we don't yet have artificial intelligence, and I'm not certain that artificial intelligence is that easy to use in the bladder, because again, it's an extremely complex organ. We know that the structure of the trigon is not the same one as the lateral aspect of the bladder. We know that when we do, we look at a bladder for an old menopausal lady, we may have some hyperplastic or metaplastic, epidermic metaplastic areas which go white and flat, which are actually quite normal, and so on. So we have to consider the organ in its complexity, but also in its changes along the lifespan of the patient. Imagine trying to do a thorough bladder examination of a man with many diverticuli. Not easy. How do you do that? How do you train yourself to get into a diverticulum and to review the entirety of its lining, and so on and so on? So I do believe that white light by itself is limited. I do believe that the white light imaging that we used to have with old systems, meaning we're not a 4K screen or not a video imaging. I mean, do we all agree that when you look at the bladder using a video scope, flexi video, we have a better vision of the mucosa than when we look at a rigid telescope? Do we agree on that?
Definitely, yeah.
Definitely. Yeah. Helena is not sure. Not?
I think sometimes you can get really good views, and we do use the 70 degree quite a lot, actually. But yeah, not absolutely all the time, but you're right. Yeah, to look back on yourself, the only way you can do it is with a flexi. Yeah.
And actually, the fact is that the way we transmit information from the bladder to the eye and the brain of the surgeon is very different from a rigid telescope and from a videoscope. And the optics is also important. We know, we all understand the concept of pixels. We know that it's better to look at a screen when we have a very high number of pixels as compared to something with very few of them. So whenever somebody is doing expert TURBT, he requires or she requires to have modern equipment. It's not good to use a system that was produced 30 or 40 years ago, and that's still working, but it's not working as well as it does now. I remember when I switched, because I'm old enough for that, from the fibroscope to the videoscope. And all of a sudden, I said, ooh, that many information? With a fibroscope, we could hardly see some flat lesions. Super difficult. We could hardly see some up to 5 millimeters wide papillary lesions or hyperplastic. Now it's easy to do that. So we are highly dependent on the quality of the equipment that we are using. And
What,
so
what are you using now? Are you using MBI and PDD, or are you using only PDD or only MBI?
I'm always using NBI because
Yes.
NBI is available
You just
as
have
a
it,
push
yeah.
of a button when you use the Olympus system. I do believe that when you have the stored system, there's exactly similar, but with a different computer processing of the images. So for me, the bare minimum is NBI, is white light plus something else, NBI or
PDD.
the stored system. PDD is slightly different. PDD is not, and I was discussing in terms of detection. PDD is slightly different because up to now, we didn't have a video scope that was PDD, how would you say, PDD amenable, PDD, PDD, please, Helena? The PDD video.
Enabled, yeah.
Yeah, enable. Thank you for the word. PDD enable video scope. So in terms of detection, that was not easy to use. In terms of surgery, that was meaning we used the PDD system using a rigid resectoscope. That was not a big burden. The burden was in the organization, and the burden came from the price of the system, because it's true that if you have to invest a few €100 or pounds to get some better vision, you better demonstrate that it does improve the outcome of the patient. And in fact, it does. It does. It does for superficial or not muscle, not TA low grade. It does also for high grade lesions. But you have to use it sparsely, or actually wisely. For instance, for me, there's one indication which I don't understand is and I'd like to have your insight on that, Helena, by the way. It is when you use PDD at a re-TURBT after resecting a T1G3. This I don't get the point, because the bladder will be inflammatory, and what you're looking at for actually is not a satellite lesion, which you might detect better with the PDD, but you are looking at a deeper invasion, which you don't have any clue with using the PDD. So, Helena, are you using PDD when you are resecting a T1 high grade lesion?
Sometimes is the quick answer. So it depends who has done the initial operation, where the initial operation's been done. We're a tertiary referral centre, and whether the first operation was done with blue light or not. If it wasn't, then yes, we are sometimes going back for the re-TUR with blue light. And as you quite rightly say, it's to check the deeper layers. But actually, if you haven't had blue light at that first operation, you don't know whether the rest of the bladder is clear or not. So we know we're not doing it on every case, but certainly there are selected cases we would do it for, and that's the reason. And I guess we all know that depending on what your initial TURBT was like, there can be some residual disease as well. So it's really to make sure you have absolutely cleared and classified that bladder at that point if it wasn't done at the first time.
That's a very important comment, because we know that the outcome of a T1 high grade plus or minus carcinoma in situ, which would be better detected using the PDD, is very different.
So yeah, absolutely. And you need to know for that patient. Yeah.
Okay.
So that you can counsel them correctly.
I don't have anything to object to that. So saying that if it wasn't used initially for the first resection, you would recommend.
If it was used for the first resection, it was done by one of our non-muscle invasive bladder cancer consultants. No, I don't think there'd be any benefit. But we're probably also doing less re-TURs as well. So because we know certainly that our pickup rates for muscle invasive are incredibly low. It's about 2% in our institution in terms of so yes, we're probably doing less redo TURBTs as well. Again, depending upon what the initial operation was like, who was doing it, adjuncts, etc.
I think this is a very important comment that you just made, because in the guidelines, in the book, it's written re-TURBT, period. no question about that. But where does this information and recommendation come from? It comes from the fact that in the initial studies that were not performed in Europe, by the way, where the surgeons are maybe more interested in TURBT than elsewhere, the rate of residual disease at second TURBT were extremely high, up to 60%. We never had those rates. And the best way to decrease those rates is rates of residual disease in the depth of the resection, is to improve the quality of resection. And to improve the quality of resection, you have different ways to do that. I'm very keen on, as you all know, on en bloc, because I believe that using the en bloc is actually dissecting the tumor away from the bladder wall and not cutting it in pieces and to scoop them out of the bladder. So the quality of the vision, the better understanding that we may have now of the structure of the bladder, possibly by the way imaging, MRI, and different advances in surgery, I suspect that in the future we might say that if you're in your own institution, the rate of residual disease after T1 high grade is lower than that. There is no need to re-TURBT, because re-TURBT is not an easy it's not an easy surgery, because what you want to do is to go deeper. You were already deep, and then you want to go deeper. And in some location in the bladder, the locations where you don't want to go too deep, actually.
Yeah. That's correct. For the sake of time, we should move on. I would like to thank you very much, both of you, for such an enlightening discussion, and talking to you has been a pleasure. Thank you very much, and goodbye.
Goodbye.
Thank you very much. Bye-bye.
And many thanks for the discussion. Bye-bye.